hypothyroidism, calcium disorders, and a keen interest in bone disease. In 2020, Dr. Waung joined the Red Cell Unit at University College London Hospital to provide regular clinics focusing on bone health. After presenting at our conference in February 2020, Dr. Waung went on to work as a consultant, treating patients who are fighting for their lives from the coronavirus throughout the pandemic. We're extremely grateful that despite his busy work schedule, Dr. Waung is here to present to you today. We are currently working with him to fund and design a research project that specifically focuses on bone health and thalassemia, and we will update you on the progress of this later in the year. Dr. Waung, thank you for being with us today, and now over to you.
Thank you very much, Theo. So first of all, thank you so much for inviting me for second year in a row. I really enjoyed last year, and I'm really grateful to be part of the thalassemia community. So I'm going to start today with a poll about some questions relevant to today's topic, which is about bones and stones, stones specifically being kidney tract stones. If I could get everybody to go to www.slido.com, and then this is the code. And then, shall we have the first question? So the first question is, have you ever had a fragility fracture? And then shall we leave, there we go. Okay, so a fragility fracture is defined as a fall from standing height and no other trauma and resulting in a fracture. Okay, so I don't know how we can work out the progress of this, but maybe we'll close the poll in a few seconds. Oh, I can see we've got 62 participants, so, and it looks like the top right-hand corner is the response rate. Shall we try to get over 30 at least? I've got 4 questions. Okay, shall we close that poll? So there we go. So that's, we've got 71% no, 29% yes. Okay, good. Can we do the next question? Have you ever had a urine tract stone? That's a kidney, that's a stone anywhere in the urine tract from kidney to the ureters which deliver the urine. Okay, so that's, shall we say, of 35 members, we've got 34% have had a kidney tract stone. Next question, please. Have you ever had a measurement of urine calcium? So that's, it should be done as a 24-hour collection where you pee into a bottle for an entire day to collect urine for calcium. Okay. Oh, all right. And so that's 47% said yes. And then shall we do the next question, which is, have you ever had a high urine calcium? There's a question, is that for thalassemia major, intermediate, or minor? So this is for everybody with thalassemia. I think, so the intermediate or major, shall we say, sorry. Okay. 18%. So, good, okay. So, perfect. So I'm told I have, let's see, you can control view options. I'm just trying to see how I can control. Sorry, can I ask for the next slide, please? Okay, thank you. So, so the outline of today's talk, we've done the audience voting already. I'm going to talk a little bit about osteoporosis fractures in beta thalassemia. And I'm generally referring to beta thalassemia major and intermediate. I'll be talking about bones, urine calcium, and kidney stones, asking how common are they, is there a relationship between stones and bones, and then tell you a little bit about what we're going to plan to do at UCLH and Whittington Health, the red cell teams, and then finally end with some take-home messages, practical tips about what you can do. Next slide, please. So that's the next slide. Perfect. So after last year's patients conference, I actually wrote an article for the UKTS magazine. So I'd recommend you have a look at that. That's the winter edition. And this is just a very small recap. So the graph on the left is, so on the x-axis is age, on the y-axis is bone mineral density. And the way we can look at the amount of bone is you can use something called a Z-score. The Z-score is comparing somebody to a person of the same sex and same age. So a Z-score of 0 means you've got an average, you're right in the 50% line, average bone amount of bone or bone mineral density. And a positive Z-score means you've got above average, and a negative Z-score below average. So what this graph is showing us is that even from a young age, people with beta thalassemia have a lower Z-score, so they have less bone, and the proportion that have a low Z-score increases over time. And so this is really a way to show that people with beta thalassemia, even at a young age, have low bone density or less bone and have increased risk of osteoporosis. And then on the right is some of the fracture data. So the top two studies are an Australian study and a North American registry study, both of which show fracture rates of around 12%. And then when there's cross-sectional self-reporting, that's just asking patients whether they've had a fracture or not. For thalassemia major, it's 35% have had one or more fractures, and thalassemia intermediate have 50%. So from today's audience, that was fairly similar, as 29% said they've had a fragility fracture. And then vertebral fractures, this is along the spine, 13% in a Thai study, and that was quite a young population as well. Next slide, please. So the interplay between thalassemia and bone disease is extremely complex, and there's so many factors that influence it. But today's talk really is focusing on one small area, which is looking at whether low bone mineral density, or surrogate marker for low bone mass osteoporosis, whether there's a relationship between that and high urine calcium or hypercalciuria and kidney stones. And just for the purpose of this talk, when I talk about kidney stones, I'm referring to stones anywhere in the urinary tract. Next slide, please. So there's actually quite limited data on this subject. So Professor Porter's team shared with me a little study they looked at in the late 90s, where they found 9% of patients with beta thalassemia major had kidney tract stones. But if you look at the published literature, there's very, very little information. There was an Australian study, and this is probably the largest, which looked at 166 transfusion-dependent thalassemia, and it showed a high prevalence of stone disease, 18%. So this compares to about 5.2% in the general population. And in this study, men had a particularly high prevalence, so up to 5 times their non-thalassemia counterpart, whereas women, it was about twice their non-thalassemia counterpart. And so the question is, could this be one of the reasons that explains why bone disease seems to be a particular problem in men compared to their non-thalassemia counterparts? Kidney stones were associated with higher body weight, older, and were more common in male. And urine calcium was only collected in less than half of those with stones or other study participants. And there were 5 other patients who had high urine calcium but didn't have stones. And then the same investigators looked a few years later specifically at the subject of kidney tract stones in thalassemia, and they found that 59% of those who were studied had kidney stones when you scanned them with a CT scanner. But this was a very small study. This was 27 patients. And the main strength of this was that they looked at what types of stones, and a bit more about that, which I'll talk about later. And one of the themes that emerged from these studies is that hypoparathyroidism, that's where the parathyroid gland that sits in the neck, which is a major hormone that controls calcium levels, both in the gut, in how much calcium is absorbed from the gut, how much is released in the kidneys, and also controls calcium in the bones. That was a major factor for having stone disease, where twice the number of patients who had hypoparathyroidism had stones compared to those without hypoparathyroidism. Somebody's asked what TDT is, so that's transfusion-dependent thalassemia. Splenectomy is another factor that is a risk factor for stones and high uric acid. And the reason is that after a splenectomy, there's a higher turnover of red cells, and so increased production of uric acid. Next slide, please. So in terms of kidney stones and bone density, I first started looking at whether is there much data in the general non-thalassemia population, and probably the best study is a meta-analysis. So this is a study that looks at lots of different studies, and they filter down to 28 key studies, of which about half of them had bone mineral density data as well. This compared 1,595 patients with stones compared to 3,400 healthy controls. And patients who had lower, and they found that people with stones had a lower bone mineral density, that's both at the spine as well as the hip, and that the degree of calcium in the urine corresponded inversely with the T-score, that's the bone density score in the femoral neck, which is the weakest part of the hip. So in other words, the more calcium loss in the urine, the lower the bone density in the hip. And they had 4 studies that showed clear increased risk of osteoporosis. There was 4 times the risk of osteoporosis seen in 2 studies. and from 4 pooled case control studies, the fracture risk seemed to be increased by 15%. But then in 2 other longitudinal studies where they traced patients over many years, there was a trend, but it wasn't statistically significant, showing that those with kidney stones had a higher risk of fracture. So I think the take-home message from the non-thalassemia population is, I think there seems to be pretty good evidence that high urine calcium loss and kidney stones is associated with poor bone health and fracture risk. So then, next slide, please. So in beta thalassemia major, we know that low bone density is also associated with low bone density and fractures. And this was from that Australian study that I discussed earlier. It also showed that kidney stones was associated with a low femoral neck Z score that I talked about earlier. It was associated with fractures. And amongst patients who had fractures, 30% of them had had a kidney stone, whereas 17% of those without kidney stone had had fractures. And those with a fracture, 27% of them had had a previous stone, compared to only 15.8% of those who have not had a fracture. And after adjusting for several different risk factors, only men had increased risk of fracture if they've had a previous kidney stone. But you have to remember that this was the patient numbers were very small. So in terms of getting statistical significance, it was quite difficult to achieve. Next slide, please. Can we move to the next slide, please? There we go, thank you. Now in terms of looking at stone types in thalassemia, I'm going to start by saying that I'm an endocrinologist. I'm not a specialist at looking at stone disease. So that's typically a urologist or a kidney specialist that looks at that. So the Australian study where they looked at only 27 patients, 16 of them had stones, but they did some really detailed analysis. And they used a CT scanner with 2 different energy waves, and they were able to detect what types of stones they had as well. And it showed that 69%, almost two-thirds, had more than 1 kidney stone, and about 60% had more than 1 type of stone. And so in this table, I've put the study on in the second column with thalassemia, and then the third column is the general population, which I've used from a few different studies. And it showed that in the thalassemia group, calcium oxalate or majority calcium stones were the most common, but not quite as high as in terms of proportion as the general population. But there's some other types of stones like struvite stones, which are classically associated with kidney infections, which were very common, and cystine stones, which are classically associated with a metabolic problem or possibly kidney tubule damage, were again disproportionately high in thalassemia patients. And then brushite stones, which are a subtype of calcium phosphate stones, these were again disproportionately high in thalassemia patients. And these tend to be harder to treat and can be associated with hypercalciuria or high urine calcium. Surprisingly, uric acid stones in this study weren't particularly high, but we know that splenectomy is a risk factor for that, so that's relevant for thalassemia population, and obesity is a risk factor as well. So can I, next slide, please? So the main point of showing you all these different types of stones is to say that the advice and treatment of the stone, some bits are generic, but many bits are quite stone specific. So you would do different things for a cystine stone compared to a struvite stone. So with cystine stones, fluid intake is particularly important, so they need to really hyperhydrate, a low salt, low animal protein diet. These are generic for everybody, but making the urine more alkaline is important. So that's the potassium citrate. So I'm not going to go into all of the different treatment options for these, but really the take-home message here is, unless you know what stone you're dealing with, it's difficult to give more specific advice about how to prevent more stones from reoccurring. Okay, next slide, please. So, so the next one of the questions is there a difference between people with stones and without stones in terms of their chelation treatment? So, so there was a North American study of 5 different thalassemia units and they looked at 216 patients, and in this, almost a third had high urinary calcium. And those who were regularly transfused, it was 32%, compared to those who didn't require regular transfusion, it was only 11%. So transfusion is a big risk factor for stones. And in this study, mainly because of when it was done, there was a relatively low proportion who are on XJade, that's desferoxamine, but whereas the majority were on deferoxamine. And then more recently, a single Greek center study looking at 92 patients found that about 10% of them had developed kidney stones with colic. So this was symptomatic stones, compared to only 1 out of 93 patients who were on different chelation treatment. And then there was an Australian study that looked at XJade or desferoxamine in particular, that showed that there was a high urinary calcium and it seemed to be dose dependent. So it seems to me that stones and high urinary calcium are common in beta thalassemia. It can't just be related to XJ treatments because it predates that and it affects people not on XJ. But there is this possibility that there's a dose response with XJ treatment and increased risk of high urinary calcium. Next slide, please. Okay, so so the next question is osteoporosis itself a predictive factor for kidney stones? So in the top 3 lines, this is in the general population, and these were really quite a large number of patients, and you can see that quite consistently having osteoporosis increases the risk of also having kidney stones, and that's somewhere around 1.4% risk. So that's really quite remarkably consistent. Now, with beta thalassemia, we know that for each, so in one of the studies, for each 1 unit reduction of Z-score, that's 1 standard deviation further dropping in bone mineral density, there was about it's associated with a 1.6 times increased risk of having a stone. Next slide, please. Okay, so so what do we plan to do about it? So so this talk was very useful because it allowed me to brush up a little bit on something that we've decided to study, but it's a bit unusual to talk to you about something that I don't know an awful lot about yet. So we've now formed an interest group with hematologists, urologists, and bone specialists who look after people with thalassemia. And we're really going to answer some of the questions that I've shown you already, which is really, what's the interaction between these conditions? How common are stones and hypercalciuria? Is there a relationship with chelation agent? And is there a relationship with bone health and fractures? And then, of course, we plan to disseminate this knowledge through publications, guidelines, and if you'll invite me back, possibly next time at the UKTS patient conference. So last slide, please. So this is the last page, which is about practical tips and take-home messages. So I hope I've convinced you that kidney stones are quite common in beta thalassemia, and really we don't know whether we need to screen for them, but we think the answer is possibly yes. But certainly if you've got some symptoms that are suggestive of kidney tract stones, so that's blood in the urine, either blood that you can see or microscopic amounts that the doctors can detect when they do a urine dip test, or you've got pain in your flanks, these are clear things that mean that you could have a kidney tract stone and you should be screened for that. And then in terms of screening for high urine calcium, we think possibly this should be done universally, but I think we need a bit more data to support that. And that's something that we're going to look into. And you can ask your thalassemia specialist, have you ever had a urine calcium collection? And perhaps you should, especially if you're on X-ray. And then in terms of screening for hypoparathyroidism, if your blood calcium level has ever been low, then your parathyroid hormone level should be measured. And if that's also low or it's not high, it might mean that you've got hypoparathyroidism. And this is quite common in thalassemia. Up to 15% of people with thalassemia can develop hypoparathyroidism. And if you do have a high urine calcium, it's especially important that, that you're screened for hypoparathyroidism, because that's something that might be the cause of it. And then in terms of if you do have stones, then some of the simple advice is keep well hydrated, because the amount of the volume of urine is a real determinant as to whether stones can form. So at least 2.5 liters a day of urine output or drinking is what we're aiming for. Avoid sweetened drinks. And then in terms of dietary intake, surprisingly, or might seem counterintuitive, if you have a low calcium intake in your diet, that can often make stone disease worse, because calcium isn't there to bind in the gut to oxalate, which is a really important, or the major stone former. So a normal calcium diet of 1 gram to 1.2 grams a day is important, and it's important to avoid. It's important to avoid low calcium, and then you want to avoid calcium supplements because unlike calcium-rich diet, calcium supplements could increase the risk of stone formation. And I'm going to answer some of the questions at the end. I've left quite a few minutes at the end, and then you can check your calcium intake. Having a low salt diet, so less than 5.8 grams a day, is important, because that will reduce urine calcium and increase citrate in the urine, which is a protective factor. Avoiding high animal protein diet, so less than 1 gram per kilogram body weight a day, and high fiber diet, and then not smoking. So that's last slide. So that's the end of the presentation, and I'm going to answer some questions. I can see that there's been a few things posted in the Zoom chat, so I'm just going to bring up the questions and then go through them one at a time. Okay, so hopefully I've answered some as I've gone along. So the first question is what's a TDT? So that's transfusion-dependent thalassemia. I'm afraid, sorry, I do not have the confidence limits for the individual figures to hand. For the purpose of simplicity of message, I didn't include those today, but certainly I've included the references, and so they would be quite easy to look up. Would you be interested in other centers collecting data to add to yours? Absolutely, I would. We haven't completely figured out yet what we're going to do in terms of data collection. but this is kind of the start point. So I think the vision or the goal, I think, would be to have a kind of UK-wide understanding of what's going on, because I think this is a problem that's certainly not going to be limited to London. And then let's see, is hypoparathyroidism treatable? And if yes, does that turn into meaningful reduction in the risk of kidney stones? So that's actually a really tricky question to answer. Hypoparathyroidism is one of the very rare hormone deficiency conditions where we do not treat the deficiency by giving back the hormone. What we do is we give activated vitamin D, and that helps restore calcium levels, but it doesn't do an awful lot to lower the calcium in the urine. But what we can do is we can treat it with thiazide diuretics, which have the effect of lowering calcium in the urine. And there's some trial work looking at giving parathyroid hormone as a treatment for hypoparathyroidism, but that's certainly not universal. And to my knowledge, there's no data about that in thalassemia. So that might be something of interest. Can I just check with the organizers, are there other questions that would be on Slido, or are these all the questions that would be in the chat?
We're just looking. I'll let you know.
Thank you.
Dr. Waung, maybe we can just emphasize some of the lifestyle tips that you mentioned. I think they're quite important and very useful.
So the lifestyle tips. So keeping well hydrated. So keeping well hydrated, I think, is simple to do and absolutely kind of paramount. So that's for people with established, so who have either high urine calcium or stones, but certainly keeping well hydrated in general is not going to do you any harm. So that's, I think, a really simple tool. And then some of the other factors will have benefit not purely related to kidney stones and bones, but actually your general health. So a low salt diet. So the average UK salt intake is 8 grams a day. So a target of less than 5 grams a day will significantly reduce the amount of calcium in the urine, and also help lower your blood pressure as well, and protect from cardiovascular disease. So that's something that can also, it's fairly easy to do. And then in terms of working out how much calcium is in your diet, the main source of dietary calcium is dairy products, and actually the UK average is we're slightly deficient in our calcium intake. It's about 700 or so grams, and so with thalassemia, where there's probably a loss of calcium net and a high prevalence of poor bone mineral density, having an adequate calcium intake is absolutely important. And if you look at the UKTS thalassemia bone disease article, there is a link to a survey. It's not a survey, but an online questionnaire where you can work out what your daily calcium intake is. And that's also on the Royal Osteoporosis Society website as well. So the question is there a link between salivary gland stones and with bone health? So the short answer is I don't know. I've not looked at that subject, and I simply don't know enough about salivary gland stones, and I think, but I think the prevalence of them probably is going to be quite a bit lower than kidney tract stones. And with kidney tract stones, they're definitely vast majority calcium related. So physiologically, I think I'm more likely to have a link with bone disease. So I don't know enough about salivary stones to be able to tell you. Okay.
Okay, lovely. Dr. Waung, thank you so much. It was a really, really informative presentation. I'm sure our members have got a lot of benefit out of it. So thank you very much.
Thank you so much for inviting me.
Cheers. Thank you. Oh, do you want to say that again? Hi, Dr. Waung.
Right? Yes. Yes.
If there are any follow-up questions that our
Yes.
members have, is it okay if we send them to you and we can sort of follow up on that?
Of course, of course, of course.
Fantastic. Thank you very much.
All right.
Okay. Thank you.
Thanks, everybody.